Hello and good evening. My name is Dr. Reed Tuckson, and I am the co-founder of the Black Coalition Against COVID. And we are so excited to welcome all of you to this town hall, bringing together our 4 minority medical societies, along with their counterparts in the advocacy community, as we move together to enhance our shared and collective ability to fight this pandemic all the way to the end. We're so close, and now all of us have to really double down to get this done. We are partnering tonight with the White House COVID-19 response team, the White House Community Corps We Can Do This campaign, the CDC Foundation, our 4 minority medical societies, and the National Black Nurses Association, the American Public Health Association's Alliance for Disease Prevention and Response. A special shout out to Susan Poland, who is my co-collaborator for this effort. We're also glad to be joined by people from Salute America, the Health Alliance Network, the Asian and Pacific Islander American Health Forum, the Rural Health Service Provider Network, A.T. Still University, the Sault Ste. Marie tribe of the Chippewa Indians, and the Mixteco Indigenous Community Organizing Project, the National Urban League, the Ad Council, and blackdoctor.org. Our goal tonight is to provide all of our audience, everyone out there, with the latest information and expert opinion on what's going on with COVID epidemiological trends, how we're doing with the current rates of vaccination and vaccine acceptance in the minority communities. We're here to update on the federal agency plans and other major national support services that can help us to gather greater and better vaccine acceptance and administration in our minority communities. And finally, to engage in an informed and experience-driven conversations that are designed to explore the barriers and identify the solutions to COVID prevention, vaccine acceptance, and administration in our communities, a conversation that we hope continues long after this meeting. Again, the backdrop for this conversation is that we are in a very specific and dangerous historical moment. We, over the next month or 6 weeks, this will be whether we win or lose this fight. And I think all of us understand that however tired we are, this is the time to double down. Well, to welcome us, I'm pleased to introduce my colleague and good friend, Dr. Georges Benjamin, the Executive Director of the American Public Health Association. Georges?
Hi, thank you, Dr. Tuckson, and let me just thank you and the members of the Black Coalition Against COVID for all the hard work that you've done. And those of you in our listening audience, I want to welcome you tonight for a very, very important conversation. And I think, as Dr. Tuckson pointed out, it is extremely important that we get into the end zone here, as to take a sports metaphor. If we don't do this right, we will find ourselves on the 15th yard line, bobbling the ball and losing the game. And so we need to really work hard to get there. And what we're doing tonight is demonstrating the power of coalitions and networks. We have lots of coalitions that have come together to do this so that you, the listening audience, can see that we're speaking with really one voice. So again, thank you for being here with us tonight. And I'll turn it back over to my good friend and colleague, Dr. Reed Tuckson.
Well, thank you so much. One of the things that that is so important is that we, at least as we get ready to get into our specific conversation, is there are a set of assets that are made available to us that many of us may not fully know and be aware of. And so before we get into the meat of the discussion, I'm pleased to bring 2 people into this town hall. The first, Dr. Mark McClellan. We all know Mark very well from multiple leadership positions inside of the federal government, but he is now the director of the Robert J. Margolis Center for Health Policy at the Duke University. We have him here tonight because he is an extremely important senior member of the National Advisory Council of the COVID Collaborative, a very important resource. Mark, would you tell us a bit about what the COVID Collaborative is all about?
Hey, Reed, I'm glad to. But first, thank you for having me on with you. And thanks especially to BDO and the Black Coalition Against COVID for such important work right now. It really is a critical time with the pandemic. the COVID Collaborative is a collaboration across a wide range of organizations, from the private sector, working with state and local governments and experts in academia, that's taking several big steps to try to help fight this pandemic. One involves finding out what's working best in terms of getting vaccines to people. You know, we've talked a lot about uncertainty that people have about getting vaccines. Well, especially if you look at the Black, the Latino, some other minority communities, there still are a lot of people left, even though the numbers of vaccinations every day has been going down a little bit lately. There's still a lot of people left who want to get vaccinated, but haven't had an easy and clear way to do it. So we're working on a lot of approaches to try to make it easier, getting vaccines right out in the community. And then also a big effort around vaccine education and outreach. So a $50 million campaign in collaboration with the Ad Council, with former presidents, President Obama, First Lady Michelle Obama, all of the other living former presidents prior to President Trump, all part of this effort to help people find out about the vaccines, get their questions answered, and hopefully help us move beyond the pandemic.
That's terrific, Mark. And by the way, for those that want more information, it is being scrolled across the bottom here now. Mark, and I would just ask one more thing, is it in terms of what do you see going as the next stage of this fight as we try to get to the finish line in time? How concerned are you?
I am concerned about where we are. The variants are spreading outside of the U.S. where there hasn't been as much vaccine availability. You can really see just what a difference vaccination makes by looking at the horrible situations in places like India, parts of Africa now, and South America. We've moved beyond those levels of infections here in the U.S., but we're definitely not done. There's still variants spreading. There's still people getting infected. Hard-hit communities are still being relatively hard hit. So what is happening now that's different, Reed, one thing is that vaccines are more available. We've got even more evidence on their safety and their effectiveness, and they're getting out every big mass vaccination sites where you have to drive to them and get an appointment and so forth, but in the community. So at your local pharmacy, your doctor in your community often has access to delivering vaccines themselves or can point you in a good local convenient direction. There are more and more places that are offering walk-up appointments that can be done when it's convenient for you. You don't have to worry about scheduling ahead. So the COVID Collaborative is making a lot of the best practices for how to do this, how to work with the private sector, how to work with community leaders, including in our Black communities around the country. So a lot of resources available now that are really part of this new phase of response here in the U.S., where we have a lot more vaccines available and we're trying to make them convenient for people to get access to.
Well, that's what we'll be doing in a minute, and giving a lot more information and guidance right from the heart of those that are doing the work in the minority communities. Mark, thank you so very much for joining us, and I appreciate it. Let me bring in now Dr. Alice Chen, who is the assistant clinical professor at the Geffen School of Medicine. And she is here because she is leading another key initiative, and that is called Made to Save. And Alice is a senior advisor to Made to Save. Alice, thank you. And tell us a bit about what Made to Save is about. And don't forget to unmute. Good.
I'm always so enthusiastic and muted. Thank you so much, Reed. It's so wonderful to be here with you. One of the beating hearts of this entire national mass vaccination movement. It is inspiring to see all that you and everyone that you brought together are accomplishing. Made to Save is really trying to sort of fill a space. There's so many groups that are doing such wonderful work, and what we are doing is we are building a national grassroots mobilization and public outreach campaign to support communities of color in getting answers to their questions and making sure that they have easy access to the vaccines. So we're pulling together kind of a national table of organizations that meet regularly to share, what's going on in Memphis and what's going on in Houston and what's working here and what's working there, and really kind of learning from one another across the spectrum, from a civic engagement group that's used to knocking on doors, and that's what they do really well, to the church that's really good at bringing people together and wants to host a vaccination site, to the doctors who are, looking for a place to go and give shots, to the hospital that is, translating materials into the various languages that are spoken into the community, and really trying to stitch everybody together so that we can all use our strengths to make sure that we are reaching the people who most need to be reached. So we're open to everybody to participate. We have regular grassroots calls. We have a health table for health organizations to participate in. We're organizing constituency weeks of action. Next week is Latino Week of Action. The week after that is AAPI Week of Action, and we have a whole calendar of events after that. And we're really just here to try to support all of you in the work that you are doing, and to lift up the experiences and the learnings that folks have and can share with just the broader community.
Well, Alice, thank you so much. And listen, we're recording this, but we're also taking copious notes. And so when we are done with this show, we will have heard a lot from our community leaders, our community advocates. We'll have very granular information. And so I'm going to feed that back to you personally and the team at Made to Save, because these are the people that need the help. These are the people who are out there doing the work day in and day out, often unrecognized, not celebrated enough, and never resourced enough. And so you are the perfect person who cares enough to listen to what people need and try to help out. For those that need to have more information, you can see it scrolling on the bottom. Alice, thanks you for joining us. We really appreciate it.
Thanks so much. Take care.
Okay, thank you. Bye-bye. And now, to set the tone for the community-based conversation and to get down into the weeds of where we need to go, Mark Morial is the best I could think of to turn to. We all know Mark as the CEO of the National Urban League. Mark has been passionate about this agenda from day one. He has been a forceful and fearless advocate for supporting community-based initiatives in this fight, and he has not been shy. Mark, thanks for joining us.
Hey, Reed, thank you very much. And let me thank you, Reed, because you've been the motivator, you've been the glue, you've been the energy behind this broad coalition. We began almost a year ago on this effort to create the Black Coalition Against COVID. And we've come a great distance, but we have so much more work to do. So let me thank you and all of the people you've assembled and everyone who's been a part of the coalition to bring us to the point where we are now. The work ahead is going to be important, challenging, and difficult. When we began this effort, vaccine hesitancy and distrust dominated the conversation. We have sought to change the understanding and change the narrative, to acknowledge the history, to acknowledge the reasons for distrust, but also to encourage people to balance that against the idea that the only way out of this pandemic is through this vaccination. It is remarkable, I believe, that biomedical research and medical science was able to create a vaccine in less than a year. An effective vaccine, a vaccine that the evidence demonstrates does in fact work. From the beginning, we urged, encouraged, loudly, quietly, strategically, persuasively, that there needed to be community-based distribution of the vaccine. I myself was able to receive the vaccine at a church facility in Newark, New Jersey. The existence of and the standing up of mobile sites, mass vaccination sites, and community-based sites has to continue. I'm excited that I now see the beginnings of public advertising campaigns, and I know more will come, to give people the information they need to make the intelligent choice to be vaccinated. I would also say this: the National Urban League will soon initiate its own community-based effort, working in partnership with the Centers for Disease Control in 25 plus communities to encourage people and to provide information around the COVID vaccine as well as immunizations broadly defined. This is about our health. This is about our survival, and we must unify and help, if you will, ensure that the conversation in communities is about balancing the pros and the risks. And I think when people balance the pros and the risks, their choice will be that we have got to be vaccinated to get beyond this pandemic. So, Reed, I want to thank you and restate the absolute commitment of the National Urban League to work with you in this impressive coalition that you've stood up as we continue this journey. Because in the end, it is about healthy communities, it's about safe communities, and it's about getting beyond this pandemic. Thanks, Reed.
Thank you, Mark, and we will look for your leadership as you continue to speak truth to power. Thank you, my brother.
Thank you.
I'm now pleased to bring in Sharice Nunez, who is here. Sharice is going to be very important for us because Sharice is the insights lead for the Ad Council's COVID campaign. And what we're looking for is that we need to make sure that we have the best information possible to guide our conversation around the knowledge and attitudes that we are experiencing in all of our minority communities. And so this is our data foundation to launch our conversation. And so, Sharice, thank you so much for taking the time to join us.
Thank you, Dr. Reed. It is my honor to be here, and especially to have the honor to speak on behalf of the public. At the Ad Council, we are constantly monitoring vaccination uptake, how attitudes about vaccination is evolving, what the barriers to vaccine confidence are, and working to identify opportunities. And we're doing this in partnership with a variety of different best-in-class stakeholders. So what I can share with you today, specifically around uptake for the Black and Hispanic American community, is positive. So we have seen positive momentum, fresh, hot off the press data as of last week. Now approximately 50 to 60% of Black and Hispanic Americans have been or intend to get vaccinated. And this is on par with what we're seeing with the general population, which is at about 60%. What I can tell you is that the opportunity remains with about 30% who are still weighing in the balance with the wait and see mindset. The reality is that while we have seen Herculean effort and continued progression, consideration has in the last 3 weeks appeared to have waned since the J&J pause, which we know now has been lifted. So we went out and we conducted additional quantitative and qualitative research. And what we found is that without question, the decision to pause the J&J vaccine has enhanced FDA credibility. However, this did not translate to building vaccine confidence with that third of the population, respectively, within the Black, Hispanic, and about 20% within the general population. We've also learned that, and I have to give you the reality of the voice of the customer, 30 to 40% believe that what we saw with the J&J vaccine, that this development could be the first of many, potential serious side effects that they might hear about in the future. So as a consequence, this segment, which we are identifying as the wait and see segment, they are navigating the decision-making process as a marathon, not as a sprint. They are proceeding with caution. And we know from quantitative research that many intend to wait 6 months or are still uncertain if and when they would get vaccinated. So we're going to get to what can we do, but more information about the profile of this segment. We do know that this wait and see segment at this point is predominantly younger. Clearly, they now have the opportunity to get vaccinated, which was not the case previously due to eligibility. But in conversations with many respondents and quantitatively, we see that a lot of the younger respondents, they feel that there is limited risk. We know that the younger population tends to be less preventative in terms of their healthcare practices. They have a strong belief that they're young, they're healthy. And so the likelihood that they would, after getting sick, end up hospitalized or die is just not a reality for them. We've also learned that there still is a great deal of confusion about the efficacy of vaccines. So they need digestible information around the specifics of its ability to prevent infection, and they have questions around the likelihood of transmission. So they're open to learning, but they're very clear on what their questions are. They've also communicated that the influx or constant changing of information does tend to create a sense of confusion, and therefore leads them to want to wait until they feel confident they have enough evidence to move forward. When it comes to their perceptions of safety and efficacy, I think it's important to note that those that are in this segment, they're still not fully convinced that the benefits of the vaccine outweigh the unknown risk. So they're doing this benefit risk calculus. And in fact, many have a perception that the unknowns of the vaccine may pose unnecessary risks, or more risk than the virus itself. So safety messaging, clear, digestible safety messaging is going to be fundamental, a fundamental pillar, as it would be for any medical treatment, to building confidence in the vaccines and to translate where they are from now and convert. A few more points that I think were salient when it comes to the younger population that are within the Black and Hispanic population. They have a lot of questions or misconceptions around the vaccines and the effects of fertility. That was a big question for them. They also are questioning, will the vaccine actually help us return to normal? Okay, so can we begin to see that evidenced, see that outcome with the population that has been vaccinated? And I know with new messaging coming from the Biden administration, the FDA and the CDC, that could potentially help. So I think all of these points that have been raised really just reinforces it is important to continue an engagement approach of education with digestible, clear information that addresses their core questions, reassurance of safety, reassurance that it's normal to have questions, also acknowledging that it is a personal choice and helping them get to that informed decision, and ultimately empowering with information. So really inspire consideration by creating a surround sound of facts, again, that confirm safety, elevate testimonials and personal stories to help demonstrate the protective benefits and the outcomes of getting vaccinated. And of course, lastly, what has already been mentioned, the importance of credible messengers and really building a cultural consensus and connection in partnership with medical professionals. I mean, because they do carry a great deal of weight in validating that the vaccines are effective.
What are we hearing, or I don't know how much data you may have around some of the different ethnic communities? Are you seeing from your surveying different priorities coming out of surveying different populations?
Yes. So within the context of our survey, we are looking across demographics. We do have an Asian American population. Transparently, it is English dominant. And we are working concurrently now to potentially get more work within language across the variety of languages. But I will tell you that all of the work we've done has indicated that the English dominant Asian American population are very engaged. So we do not see high barriers to vaccine engagement and intent with the Asian American population at all. When it comes to the American Indian population, we have partnered with the United Indian Health Institute, and I will have to defer to them because they've done a lot of great work on the ground to help understand the barriers. But again, even with that group, the engagement and consideration for vaccination was much higher, yet there were still elements of concern around safety.
Great. And anything in the Hispanic community by any chance, by the way?
Yes. So the Hispanic community is consistent with what I shared earlier. So they actually, across the ethnic groups, the Hispanic population is actually progressing at a much faster rate than the Black Americans in terms of vaccine intent. So they have 60% are committed. And then you have about 25% that are weighing in the balance, but open. But again, those questions for that younger population, which is really within the Black and Hispanic that I raised earlier, do need to be addressed effectively.
Well, thank you very much, Sharice. One of the things that I think all of us will hope for is that we will start targeting now the micro segments of different ethnic populations, and particularly our young people under 35. I think it's important that we really start to highlight and get at that group, which may be the big challenge coming forward.
Exactly. That is the focus, and we are entrenched right now with messaging and communication work at the Ad Council to help engage both on the air game and the ground game in reaching that younger population and addressing their concerns.
And finally, before I let you go, for those who are interested in your data and what you have available, how can we access some of what the Ad Council has collected?
I actually have a presentation that has been prepared. Literally it was shared today. And so I can socialize that to you, Dr. Reed, and then you can disseminate it as you see fit.
So we will put it on both the websites for blackdoctor.org and the Black Coalition Against COVID, which is blackcoalitionagainstcovid.org, Black Coalition Against COVID.org, and you will see Sharice's presentation with her data. Thank you so much for joining us tonight.
Thank you for having me.
Great. And now it's my pleasure to begin to get really into the where we are with the epidemiology of this disease, and also where we are with the president's strategy for making sure that we get shots in arms. There is no better person to join us than our good friend, Dr. Cameron Webb, the hardest working man in the business. He is the senior policy advisor for COVID-19 Equity White House COVID-19 response team. And he is just a terrific person and really dedicated. Cameron, help us to understand now from the epidemiological side, where are we? How dangerous where we are now? And is it possible that we could be India?
Well, so first off, let me say thank you for having me again. It's always a pleasure to be with you on these events. I think, the place that I start with is happy to give an overarching view of what the nation looks like in terms of trends. But keep in mind, every locality is different. So it's really important for folks to keep track of what spread looks like in their own communities. Certainly we're not in the same place that India is. We are seeing a lot of improvement week over week. We've seen about a 19% decrease in the number of cases from 2 weeks ago to last week, which is good news. We've had a decrease of about 10% in COVID-19 related admissions to the hospital or hospitalizations. We've seen that COVID-19 deaths have decreased by a little over 2%, and they were, down to 667 was the 7-day average over the last week. Now that's still 667 too many, right? We know that every death from COVID is tragic, but I think that as we continue to make progress, we know that since February, we've seen a precipitous drop in the number of COVID-19 related deaths, and the vaccination program has a lot to do with that. And so kind of turning to that really quickly, I think it's important to note we've gotten a lot of shots in arms. And so in total, a little over 230 million vaccine doses have been administered. We've got over 43% of the population who have received at least one dose of the vaccine. That's about 141 million folks. And then we've got 29% of the population. And again, this is the entire population that are fully vaccinated. That's almost just under 100 million folks. And so we're making a lot of progress. We know that, for adults who are 65 and older, over 82% have received at least one dose. More than 2/3 now are fully vaccinated. So we're making progress, and that's going to help keep those numbers moving in the right direction. That's going to help reduce the number of hospitalizations and deaths, because that's what these vaccines do. We know that they're safe. We know that they work in doing just that. But again, we still have to stay vigilant. We're not out of the woods yet. There's a lot of work left to go. So it's such a critical time for us. This is kind of that make or break moment. The president said he wanted to have a more normal 4th of July. Whether or not that happens now is in the hands of the American people. It's folks making the decisions to follow the guidance, the science, the best practices, or not. And that's going to dictate how soon we get out of this.
One of the things that comes out of what you said is, and I think I've got my numbers right, that that significant number of our seniors who have been vaccinated, that has resulted in about 80% decrease in hospitalization for seniors. A clear relationship between getting vaccinated and decreasing hospitalizations.
Oh, absolutely. So 80% decrease in hospitalizations, 70% decrease in deaths. I'm an internal medicine doctor. I work on the coronavirus unit at the University of Virginia when I'm doing my clinical work. And I can tell you, early on in the pandemic, we were seeing folks who were in their 70s. The average age of hospitalization were folks in their 70s. Now, as of last week, the average age of hospitalized individuals for COVID was 59 years old. So we're seeing younger individuals who are the ones who are now being hospitalized. It's in part because it's younger individuals who are bearing the brunt, who are getting more cases, who are more exposed. And so it's still all the more important for everyone to get vaccinated. So we're seeing that improvement among older adults, but again, we've got a lot of the population left to go.
And in terms of the variants, we now know, at least the last data that I saw was that the UK variant was now dominant strain in the United States, and that one is more easily transmissible and more serious when you are infected with it. Are you seeing other variants? And in particular, is there any chance that what's happening with the Indian variant, which I've heard now is in Switzerland, could wind up being here in the United States?
Well, there's always a chance, in a global economy, there's always a chance that any variant can find its way here to the United States. These variants, they have their names in part because that's where they were first identified. So that so-called UK variant, the B.1.1.7, that not only got here to the United States, it is now the dominant strain. So that's the variant we see the most often. The South Africa variant, the B.1.351, again, we have, lots of instances of that here in the United States. It's not as common as the B.1.1.7. We've got the California variant, the New York variant, again, lots of different variants of concern here in the US. So we're keeping a close eye. We are doing a lot more genomic sequencing at this point. So we're getting a better handle on what's out there, what's circulating, and that'll help us keep track. But in terms of the dynamics in India versus dynamics here, very different. I think the first thing from our standpoint is always make sure our testing is adequate, make sure people have plenty of locations to test, and then make sure we're maintaining that sequencing so we can identify where there are problem areas. Because again, that's what we've known we're in a race against this entire time. Vaccines against the variants. We need to get more people vaccinated fast enough so that the virus has nowhere to go. It has no more opportunities to continue replicating. Every time a virus is replicating, that virus has opportunities to make copying errors. And when it makes copying errors, that's what creates variants, right? Some of those have a survival benefit, and that's what creates these variants that are problematic, like B.1.1.7. Others of them don't have a survival benefit, and so they don't last. But every time a virus is replicating, every time it's in a body creating more of itself, which is what it's built to do, it's creating opportunities for variants to be created.
So when our audience hears this, and as they start to counsel either their patients or their constituents, isn't this the reason why, again, we're saying wear your mask and don't listen to these crazy commentators on network TV that tell you not to wear them, or certain governors are saying not to wear them? I mean, isn't this the reason why we have to keep at this?
It is. And, the CDC has been really vigilant about this. There were new guidelines about mask wearing that just came out yesterday. We've said over and over again, we're going to follow the science on this. And so every piece of guidance that we're giving is rooted in some increased or enhanced understanding of how this virus is moving, how vaccinated our population is, and how to mitigate risk. And so the risk mitigation strategies are still the same. We've been doing this for a year and 3 months now, practically. We've got wearing masks, keeping physical distance, washing your hands, and when it's your turn, get the vaccine. Those are the tried and true elements that keep people from getting infected. So yes, those remain the standards. I think what we know about vaccinated individuals is that their risk is significantly lower. And so particularly in outdoor spaces, that new guidance was saying in outdoor spaces, if you are vaccinated, we know these vaccines are incredibly effective. And so yes, it does allow us to take another step toward normalcy. But again, in the absence of protective elements like vaccination or mitigation like mask wearing, people are still at risk. This virus is the same virus that caused so much harm over the last year and some change. So it's so critical to keep working.
And so on this issue about what you can do when you are vaccinated, I was very intrigued by the announcements yesterday that, if you are vaccinated, there are things now that you can do to really get your life back. Are we being too cautious about what we can do if we are fully vaccinated?
I think some of that's a matter of people's risk tolerance, right? I think we're exercising the right level of restraint to acknowledge and respect what this virus has done, not just to our families, to our communities, but to our society. So if we're respecting and acknowledging all that this virus has done, then we're going to be cautious. We are going to take it one step at a time. We're not going to turn things around too quickly, because we know that the better part of valor for us is taking a step at a time, making sure that we're not creating more problems, and then continue moving forward. We saw this last year, right? We would see people rush to open things back up, and then we'd take 2 steps back. And it kept happening to where we were worse off than we were when we first started the shutdowns in March and April. So it's so important for us to take these steps incrementally forward so we can end this pandemic. And so, I'm not opposed to the level of caution here. I think that that's been the hallmark of this administration. It's been focused on safety. We've been focused on science, and we've been kind of taking our steps, taking our cues from the scientific experts in this space, really leaning into that evidence base that's there. So I think it's the right step. I think that, as things continue to move forward, we'll let you know. We want things to get back to normal as soon as possible too. So we're all on the same page. I think it's just a matter of, us wanting to continue to make progress.
Well, I think it really tells people, though, that why you should get vaccinated, because there's a whole bunch of stuff you can do and start to get your life back. And so I think that's great. Before I let you go, let me just say that the administration, the Biden-Harris administration, should be very proud that the rollout of the vaccine has been beat its own goals and objectives. And so it's really done a great job. I know now, though, the issue is that we know that we need to get more access conveniently located into communities of color. And I know that you have personally taken this on as one of your cause celebs. What can you say to this audience of minority health professionals and advocates about availability of programs that are utilizing community-based and faith-based organizations?
Yeah, that's going to absolutely be the key. I think as we move into this next phase, I always tell people this first, 55% of adults who got vaccinated, we were saying that was the easiest 54%. It's the folks who were either eager to get vaccinated or who had more ready access. As we move into getting this next big, cohort of individuals vaccinated, making sure that more and more people have that opportunity to get that shot of hope, as we say, it's going to be all the more important that we're leaning into things like trusted messengers. So as health professionals, you're really a key to that effort. Folks are looking to you. There are a lot of people out there who still have questions. And even though we've been at this, vaccination effort for several months now, it's completely warranted and okay for folks to still have questions. Our job is to avail ourselves to folks and to continue to answer questions as long as they have them. What we found is that when people get good information, they make the decision to get vaccinated. And so that's what we have to keep doing. But we think pairing good information and trusted messengers with vaccine is kind of the best course. And so, yes, leaning into using primary care providers as vaccinators, that's going to be a key. Partnering community-based and faith-based organizations with our pharmacies or with our federally qualified health centers, that's going to be a key. People need to know that the places that are offering themselves to vaccinate the community are places that they trust. That's going to be the key to getting this next group of folks vaccinated. That's going to be a real key in equity. And I appreciate you applauding, the administration hitting some of the goals, but just know we're not spiking the football. Nowhere near it. I think from our perspective, we've got a long way to go. We've got a lot more people to protect, a lot more lives to save, and we're going to keep working.
Well, I'm going to let you go, Cam, but I know you'll be tuning in off camera, and you're going to hear from these 4 panels of minority health professionals and advocates who will have a lot to say about ways in which they think you can continue to help them in this fight. But I want to just give all due credit to you for your listening to our communities, you're paying attention, and you're responding appropriately. So thank you so much, Dr. Webb. We really appreciate it.
Thank you. Thank you all for your work, and I'll be all ears. Looking forward to hearing the rest of the meeting. Take care.
All right. Thank you so much. And now we have our pleasure to bring in Dr. Lauren Smith, who is the Chief Health Equity and Strategy Officer at the CDC Foundation. And Dr. Smith, the CDC Foundation does have a treasure trove of assets as well that our audience will be interested in availing. And can you start by giving us a sense of some of the support that you all have for community-based organizations and faith-based organizations?
Sure, Will. Thank you so much, Reed, for inviting me and for all the work that you were doing with these tremendous town halls. The first thing I wanted to share is the focus that we have been having on community-based organizations, just to pick up on what Dr. Webb was talking about in terms of those trusted individuals and organizations in communities who are understood to have credible information, have been there for a while, will be there for a while. So they're not just, coming and going. Those are the groups that we've been looking to support with the vaccine, both education and answering the questions in the way that Dr. Webb was just talking about, but also in making the vaccine even more accessible by getting the vaccine to places where people are. We know that community-based organizations are a vital component of healthy communities. And so that's why we've been looking to really invest in them playing a really key role. And we've been fortunate to be able to do that with support from federal funds through the CDC itself, but also through private and other foundations who have provided funding to be able to do that. And I would say some of the groups we've been able to support include, as an example, focus campaigns in New Orleans, Jackson, Mississippi, Albany, Georgia. We've been pleased to support the National Hispanic Council on Aging, specifically focusing on Latinx elders. So those are some examples, but that's really key because we know those are the folks that people will respond to.
Well, we really know that it's important. One of the things that, and I don't want to presuppose what some in the panels will say, but I know from the work that we've been doing and the many town halls that we have been conducting, there can be a frustration on the part of many CBOs and FBOs because they are, sometimes it feels like when you're a minority group doing this work, people take you for granted and think that that because your mission is to do all these lovely, angelic, saintly-like work, that you'll just keep doing it. And meanwhile, other organizations wind up getting the funding and the money. I hope that you and your colleagues at the CDC Foundation and at the CDC generally understand that we've got to change that.
I think you're absolutely right, and that is in fact the main motivation for the approach to funding community-based organizations that we are doing. In fact, the foundation I guess it's been almost 2 weeks now, released an RFP specifically for community-based organizations, up to 100, in fact, to be able to do exactly this work.
Great. And now talk a little bit about some of the efforts you're also doing with this Health Action Alliance, which I've been very intrigued by, and I don't think a lot of people know what that is.
Well, I think it's important to recognize that there are multiple players, and I think you and Dr. Webb, I think, articulated it well. We can't do this with only part of the team, right? We need all aspects and all dimensions of our communities and our society to really be pulling in the same direction. So the Health Action Alliance is a group of business leaders who, recognizing that they too play an essential role in helping to end the epidemic, have gathered together to be able to get important information out to their employees, to strategize about how they can support their employees, to have the information they need to make the informed choices. We've gathered together to do this with our partners, which include the Ad Council. So you just had them on. The Business Roundtable, Robert Wood Johnson Foundation, and the De Beaumont Foundation. So this was launched in February, and the focus really is to strengthen and accelerate the business community's response to COVID, addressing the health inequities that we have been talking about this evening, and then recognizing that they too play a role in strengthening the public health infrastructure. So there's toolkits, resources, training, a whole host of things specifically aimed at providing employers and businesses with the information they need to support their workers.
Well, before I let you go, let me just wonder, just quickly, is it possible that as you do that work with the businesses, that you can encourage and facilitate their collaboration with the community-based, faith-based organizations in their community? Can we start to make a bridge so that these rich corporate assets are devoted towards the communities in which they run their businesses?
Well, I hope so, Reed. In fact, our goal is to take this opportunity to weave an even more robust fabric of public health at the community level. And we talked about the community-based organizations being part of that fabric, but business, faith leaders, all of those are also part of that fabric. And they have that saying, where our futures are intertwined, right? We're all interconnected. So I think more than anything, people recognize that during this pandemic. People, I think, saw that real time play out. So I think we have a good opportunity to do that. And I think we have to make it clear that it's not just for this particular pandemic, with this particular, infectious disease, but that it's really relevant in the future and for all of community well-being.
Well, I appreciate your leadership there, Lauren. And I just, again, hope that you can be that kind of an advocate, that kind of bridge between all these initiatives and the people that are on this town hall audience tonight, because they need everything that you have and they need your leadership. And for you to take the time to do this and be a part of this, we really appreciate it. By the way, if people want to get more information about what's available, where do they go?
They can go to cdcfoundation.org, www.cdcfoundation, all written out, .org. And there are RFP or sort of funding opportunities there. So people should check that out on our webpage. And we also, have a whole set of resources and connections for community-based organizations that we've gathered through over this past year of working with them.
And hopefully, as you all amass those assets, and I've looked at many of them, and they are very good, but they got to keep getting better. We always have to keep getting better. And again, the only way to get better is to keep talking to the communities themselves. And so that's why these conversations are so important. Thanks for your leadership, Lauren. We appreciate it.
Thank you.
Great. And now we want to bring in our first panel. And I'm very pleased to have our colleagues from the Hispanic community. And with us this evening is Dr. Pilar Guerrero, an attending ER physician at Cook County Health and a member of the board of the National Hispanic Medical Association. She's actually dialing in from outside of the ER as we speak. So if we hear ambulances or whatever, we'll know that she may jump up and run back over to the into the clinic. We also have with us Arsenio Lopez, Executive Director of Mixteco Indigenous Community Organizing Project. And Arsenio is just one of the most wonderful community workers and advocates out there. And then we also are pleased to have Emily Ramirez, Director of the Institute for Health Promotion Research and the Salud America program at UT Health San Antonio. Let me start with you, Dr. Guerrero, and sort of from the point of view of the National Hispanic Medical Association, what are you and your colleagues seeing about vaccine acceptance and vaccine administration that excite you and that concerns you?
Certainly. Well, thank you for having us and giving us this platform to let our message be heard and the people, our voices be heard. What we're seeing is that messaging is getting a little bit better, thanks to the efforts of many, many people. Messaging in Spanish is getting better. You know, a lot of our population, even back to H1N1, the most trusted source has always been church, neighbors, community members, and the news. So we are getting better with the messaging. There's less hesitancy now that proper education is being done at community levels, emphasizing to the essential workers, because I think a lot of the hesitancy that we were seeing were from people that either were afraid of losing their job, were afraid of getting tested because they might lose their job if they were to be positive, or they were just essential workers and they didn't want to know if they were positive or not. About 30% of the people in different surveys in California and in Illinois, 30% didn't, they felt hesitant just for lack of information in their own language. What we're seeing again now is a lot of long haulers, especially in coming back through the ED, because a lot of the primary care clinics are not open yet, which means they're missing more work. And that makes other people still get hesitant about getting the vaccine, because they feel like if their relatives are still long haulers with symptoms, why should they then get the vaccine if that's not going to help them? We're also seeing reinfections of people that have only gotten one vaccine. For whatever reason, people are not going for the second appointment for Moderna or Pfizer if those are the ones they're getting. And we're seeing reinfections of COVID coming through the clinics and through the ED. So, but what has worked for us, that I will say, is groups like Illinois Unidos out of Chicago, where the different stakeholders got together, over 100 people, including faith leaders, city county officials, community-based leaders, healthcare workers, public policy workers, and we all came together and applied for small grants, but we're able to build enough force that not only were we able to get the data and get the surveys out to the communities to see what their needs were, but then we're able to mobilize units to go to the communities and get them vaccinated. And that has worked quite a bit.
Thank you. Arsenio, let me turn your way and ask you, what does it look like from the ground level where you are? What are the things that most give you reason for encouragement, but what are your biggest challenges and barriers?
Hi, first of all, thank you for the opportunity as well to be in this space. Just a little bit about the community I work with is the indigenous and migrant communities, who many of them speak a different language than Spanish or English. We speak our own native languages, and we have identified quite a large of different communities, indigenous communities, like not only, for example, the larger indigenous communities in California in the agriculture industry is Mixtecos, and then followed by Zapotecos and Purépecha, Triquis, and so on. Each of these languages are very unique, and most of our languages are phonetic. That by itself creates a lot of challenges and barriers, just because of, as it was mentioned already before, information is crucial. So for individuals to make the right decisions on accepting the vaccines, they need to be informed so they can make that decision. And that's something that I think is being lacking. It's lacking not during only for COVID, during this crisis, the pandemic, but it's been lacking for so many years in the past. So when COVID hit on our communities, such as indigenous communities, absolutely, there is no information available in indigenous languages. But what excites me right now is that, fortunately or unfortunately, it's been more attention to CBOs like ours, who are developing a lot of materials like PSAs. We have our own community radio station, Radio Indígena, who has a online platform, and we also know about other CBOs in California, but also in other states of the country that are directly working with indigenous migrant communities, who are also being part of these efforts of developing all these different outreach materials, PSAs, using the different social medias, Facebook, creating Facebook Live informative sessions to provide that information to our communities. And we have started seeing it more of our communities accepting the vaccine. But one thing I would like to bring as well is that there's been historically other challenges between indigenous communities and the healthcare system. Just because of the historical discrimination and abuses to indigenous people, for example, it's being already there, and it's making our work double or triple difficult to do this. A negative experience such as, let's not forget about the sterilizations without consent. That plays an important role when it comes down to building trust between indigenous communities and the healthcare system. So, but even with all that, I feel very positive, and by seeing that more of our communities are being accepting the vaccines.
I'm not glad to hear, I'm sad to hear that what you just said, but it's important that we hear and learn each other. We in the African-American community, many of us think that we're the only ones that are upset with the distrust issues and the famous GYN surgeon, the father of OBGYN, Dr. Marlon Sims, who did his work on unanesthetized slaves, same kind of sterilizations and so forth, and all kinds of vaginal procedures. And now we're hearing the same kind of issues where you are. That's what this whole evening is also about, is learning each other and coming together in our common humanity, our shared pain and suffering, but also our shared inspiration as we all collaborate to fight this fight through the end. Let me turn to you, Amelia, and how are you seeing this? What excites you? What concerns you, Emily?
Yes. Well, thank you very much, Reed, and for doing this. And part of it is that we need to continue getting this important and trusted information to our communities. That is a number one source. And and as has been said by Dr. Guerrero and Arsenio, our populations vary. We Latinos cover a large range of individuals from Central Caribbean all the way to European. And so, and we have different ways of communicating with one another. I mean, Spanish is our common language, but our younger generation or generations that have been born here are more likely to be English speaking. But if you address them and add some Spanish words that they grew up with, that will resonate. That message will get to them. So we really need to be cognizant of the type of communication we're using to reach out to our different audiences. And so that excites me because I've finally seen some energy and synergy around this area. But what concerns me is that we still have a large amount of mis and disinformation that we have to fight. In our Latino community, there are lots of myths and misconceptions that are out there. And our communities are getting a lot of their information from some of our social media sources, which is easy to spread the misinformation or the disinformation. So, as we've said earlier, working with our trusted sources of healthcare professionals, our community-based organization, our faith leaders, that's where we all have some commonality, right? And that we need to bring us together, that we're saying, providing the same message and reinforcing the importance of getting the vaccine.
Let me come back to this thing. This a very important nugget that you dropped on us in terms of how you're learning to communicate and adding every once in a while Spanish words inside of the English conversation. Do the people who are providing your community with the ad material and the public service announcements and all of that, are they aware of this? Are they listening to that? Or is this something that we need to bring more to the attention of those organizations that are developing content for people like you all to use?
I think we need to bring it to their attention. For so long, it was either only English or only Spanish. I'm a third generation Latina, grew up in Laredo, bilingual. And so now when I have to speak more Spanish, it gets a little difficult for me sometimes. But knowing these words that I grew up with, the message resonates with me. And through Salud America, for example, we did a campaign that called Juntos, Together We Can Fight COVID. Just using that one word could make a huge difference to resonate within the community.
Would you be in touch with me tomorrow? I want to bring you in front of the Made to Save people and the Ad Council people and make sure that they are getting the insights that you just shared. That's why we're here tonight. So this is not a show and tell meeting. So would you please be in touch with me tomorrow? Dr. Guerrero and Arsenio, let me give you 10 seconds, 15 seconds each for what's the one thing you want to leave us with the most?
Well, I believe we need to continue to partnership with the National Association of Broadcasters. It's not working in silos, and that's really what we need to unify our mission. We need to reach out beyond just our little world, right? I know the NHMA is building a big hub where all the different states are going to contribute their information both in English and Spanish so that anyone can log into nhma.org and get information about COVID, what to do, where to look for help. And that's how we need to work at a local level and then at a national level, and not to forget to ask for grants, ask for the help. If we don't ask and we don't have a voice, we'll never get ahead. But as a unified voice, we definitely deserve it. Our people deserve it. And onward we go.
Arsenio?
I just want to say trust, trust, trust. I think one of the things that is being instrumental and has been key during this crisis is the partnership and the collaboration between small CBOs serving these hard-to-reach communities and public health in each of our areas. But I think there is still some work that we need to be doing between us. If they're reaching out to us as a CBOs, that we already have built all this expertise on reaching out to these communities, and they are inviting us to be part of the conversation and support them with that efforts of reaching out to these communities. They should trust us, that we know how to do this work, that we have good practices on reaching out to our communities. Because I think if we don't have trust between us, public health, healthcare agencies, clinics, and CBOs, I think it just make our work more harder to serve those communities.
Well, thank you so much. And Arsenio, I have to say also that I'm very much impressed by the challenge of so many different languages And that's really, really key. And so I'm hoping that you guys have the resources you need, but maybe drop me an email tomorrow and let's see about maybe connecting you up with Dr. Lawrence Smith, just to make sure that they may have some opportunity, if need be, to give you a little more support that you're doing, because it sounds to me like it's extremely important. Thank you all very much, and we're going to move on. You are terrific. Thank you for bringing this to our attention.
Thank you.
And now we turn to our conversation with our colleagues from the Asian and Pacific Islander community. And with us is Martina Kamaka, a family physician and associate professor in the Department of Native Hawaiian Health at the University of Hawaii School of Medicine, but she's also the vice chair of the National Council for Asian and Pacific Islander Physicians. Jeffrey Caballero, executive director for the Association of Asian Pacific Community Health Organizations, and our good friend Juliet Chow, president and CEO of the Asian and Pacific Islander American Health Forum. And Martina, let me turn to you right off the bat and ask you same questions as we just explored. What is it for your communities that gives you reason for concern, and what excites you about the opportunities for progress? And come off mute. I do that every time, so don't feel bad.
Sorry. So aloha kako, mahalo. Thank you for letting us be a part of this important conversation. I just want to start off by saying that the NHPI population, we're a small population and have been, kind of overlooked a lot of times on national matters. And unfortunately, COVID has brought our disparities up to the forefront. We have some of the highest case rates in the country in at least 7, if not more, states in the country. Sadly, about 30 states in the country don't even list any NHPI data. So my first thing of concern is that we aren't even being counted in some of the states, and the ones that we are being counted, we're seeing these huge disparities in case rates, and this brings out the whole issue of data and data disaggregation, and if we're talking about treatment and vaccinations, how can we get a good feeling for what's actually going on if we don't have that kind of data? Now, one thing that's been really positive, at least in Hawaii, is that we were the first state to disaggregate NHPIs as well as Asians. And this was critical because then we saw that our PI population was hugely disparate in the impact of COVID on them. And also when we disaggregated Asians in Hawaii, we found it was our Filipino population that was suffering from these huge disparities. So obviously our efforts towards targeting treatment, testing, and vaccination needs to really focus on those particular populations. So I just wanted to start off by kind of setting the stage with that. What is exciting is that there's been an amazing outreach with our community, with our faith-based communities, even into our schools, to try to get vaccination out. We initially did quite well with the elders. Our messaging had to do with protecting our elders, and I think that resonated. Now when we're getting into the younger population, now we're starting to see some issues with vaccine confidence. But one thing, and I think our issues are the same as many of the other speakers that have talked, but one thing I want to emphasize is that some of this vaccine confidence, the people that are having problems with that are the same people that were having problems with vaccine confidence when it comes to childhood immunizations, measles and stuff. So it's those same parents, those same families. So we haven't been able to address that well, and that's flowing into COVID as well. So that is something that we need to pay attention to. Language, we are incredibly disparate, not disparate, heterogeneous, because we have so many different cultures and languages. I think, things like putting more resources into supporting community health workers and community organizations that can get out, they're trusted, and get out in language is so important for our communities. So I'll let some of the others.
No, that's just, but no, I really appreciate those comments, Martina. Let me go to Jeff. Jeff and I just finished working earlier this afternoon, and he taught me an awful lot this afternoon in a big presentation he made in front of the Office of Minority Health. Jeff, take yourself off mute and tell us what you are most excited about and what are you most concerned about.
Thanks, Reed. I've really appreciated having this forum, being part of the forum, and so thank you for the invitation. With regards to APCHO, as a association of community health centers, we've really been excited about the vaccine access program that the Biden administration started this past February. Thus far, we've received about 9 weeks of data related to the vaccine access program that allows community health centers to receive the vaccines directly. And from 9 weeks of data, we've seen that 1.8 million people have already initiated their vaccinations, and that over 800,000 people have completed their vaccination series. A statistic that's been very hopeful to us is that 25%, it has been reported that 25% of all the administered vaccine have gone to populations that are limited English proficient. So this has really been an example of something that has been working in addressing some of the most challenging circumstances for Asian Americans and Pacific Islander communities is the prioritization of the resources for limited English proficient populations. Another area that's really been working is the partnerships between community health organizations and community health centers and community-based organizations, particularly when they are collaborating with a public health department that is leveraging them as trusted messengers. That has really worked in our communities. What hasn't worked so well are health departments and other corporations that expect our health centers and our community-based organizations to target and serve all Asians and Pacific Islander populations, particularly those that are limited English proficient, without more support. That is just not working so well. Now, that is why APCHO and several other national Asian advocacy organizations have established the Asian American Voices website, asianamericanvoices.org, to help us document the incidences, the language access rights guaranteed to us by Title VI of the Civil Rights Act are being violated. And so we hope that through the development of this site, we will be learning more about the types of situations and examples of where language access remains a problem in this country, so that we can develop rightful policies to address it.
Jeff, one thing before you continue, would you say the name of the website again so that Ellis can put it on the scroll for everybody?
It's Asian American Voices. The website is asianamvoices.org.
Thanks.
And again, this has been on already, and it'll be very critical to help us identify the situations that still need to be addressed. One point around the hesitancy issue that I just wanted to make, Dr. Tuckson, is related to the circumstances that I shared with you in our previous session. The hesitancy that we are really hearing about from our communities, it's mostly related to the distrust of government and institutions and services related to the government. I mean, we need to recognize and come to the reckoning that the last 4 years of the last administration, with public charge and similar anti-immigrant policies, I don't think anyone blames the immigrant communities to be afraid and to fear what these institutions might be trying to accomplish, despite what they're saying they're trying to do. That's why a lot of the folks, when I go to my members and to our staff, goes, do you see hesitancy? When the community gets to them, they don't see hesitancy. They said, no, they just want to hear the information from someone they trust. And they go, do you really want me to, should I really take this vaccine, doc? Yeah, of course you should. But they're not going to just listen to any Tom and Joe out there who comes around with a translated material and trust them. That's one of our biggest peeves right now, is that translated materials do not equal meaningful access.
Right. Thank
We
you, Jeff.
need communities, or trusted messengers to be able to carry that material that we have invested so much resources in to be impactful to the patients that we need to reach and get them to the vaccine. So again, AsianAmericanVoices.org.
Thank you, Jeff. That is extremely important. And now Juliet, who is just extraordinary. What's your take on this, Juliet?
Reed, Dr. Tuxson, and to everybody who's joining us tonight. So I'm one of those, I want to own it. I'm one of those recovering attorneys based here in Washington, D.C. With the Asian Pacific Islander American Health Forum. I do want to say, just applauding you and everybody who's showing up tonight. If there's another theme that I can distill or extract collectively, if you'll allow me to, collectively we're saying we're going to advocate to take care of one another. I think for me as a recovering attorney and trying taking a civil rights lens here, we also want to dispense, diminish, and get rid of this notion of invisibility, whether it is the AANHPI community, whether it is the Latino community, the Black community, the Native American community. So I do want to hold up, let's dispense with this notion of invisibility. In terms of the convenience of access, how well things are working or not, I'm going to take a slightly different approach. Words matter, and I want to say words matter, and I've used that phrase in so many different contexts, but particularly for our community and everybody who's tuning in tonight, we know that with the combination of an anti-immigrant agenda over the last 4 years, with the mislabeling of COVID-19 pandemic, words have mattered, and it has had an extraordinary, very hurtful impact on the Asian American Pacific Islander community, particularly over the last 15 months. We have seen the imagery when within days of the president announcing how we are going to uplift our communities, when the Attorney General of the Department of Justice makes a statement, then to turn around within 24 hours to see an elder Asian woman in Midtown Manhattan get beaten down, kicked down, punched, and bystanders not intervening. This is where words matter and visualization matters. But this is also looking forward, and I am an optimist at heart. This is where allyship matters and how we are all coming together. And I will say, while we can, of course, celebrate, we must celebrate our differences. We must also celebrate our commonalities when we're talking about what do we need to do to overcome and ensure our families, our communities, and our neighbors are dealing with COVID-19 and they're getting their vaccinations. And a few, three quick points. One I already alluded to. We really cannot underestimate the impact of fear that our families and our communities literally are living with day in, day out. It breaks my heart to hear that we have elders, we have family members who finally got their precious COVID vaccination, but because of the fear of the hate, they are shuttering themselves in and they are forgoing their vaccination. Maybe the numbers don't amount to thousands, but each and every life, each and every vaccination, we know collectively as communities of color, we know is very, very critical. We do need to lift up each other. I'm so glad that Martina, Dr. Kamaka is here especially to uplift the Native Hawaiian and also the Pacific Islander voice. But I also want to take a moment to uplift within the diversity, the resiliency and vibrancy that is called the Asian American Native Hawaiian Pacific Islander community, that we are also able to uplift the Hmong community, particularly in the Midwest and North Carolina, that we are able to uplift minority religious communities. But within our community, it is our Sikhs and our Muslim sisters and brothers. It is also uplifting, recognizing that within this surge of the last 15 months, that there is a growing rate of gender-based violence. So I also want to uplift our women, our mothers, our aunties, our grandmothers, and the women's organizations. Number two, structural and institutionalized barriers. Dr. Kamaka and Jeff and Dr. Reed and so many others, including the previous panels and the forthcoming panels, have highlighted the lack of disaggregated data, the lack of solutions to overcome language access barriers. Come on, folks. We as a country, we're smarter than this. We're better than this. Let's look for innovation to overcome those barriers. Absolutely. It's not an ask. I am putting it in front of us as an invitation for innovation. And absolutely, let's hold ourselves up as a country with that high bar to overcome that.
Julie, we're gonna have to leave it there, I think. Maybe let me squeeze the last one in real quick.
Yeah, the third is we need to continue to set high expectations. We do want to applaud the Biden administration for setting a new trajectory and a new high bar. But this is where I will share and underscore, not together with this community, but we need to think of ways where we can drive innovation and bolster private and public partnerships.
Well,
Thanks so
listen,
much, Ray.
let me just say, Juliet, you can see why I wanted you on this show so much. That was beautiful. Martina and Jeff, thank you. And Martina, I think what I want to do, though, is as a follow-up, based on what you said and Juliet's echoing it, is maybe see if the 4 medical societies might be able to come together, if they already haven't, to start to advocate more with the ASTO and NACHO crowd to get more of this data done. I think we've just got to get at it. And so, Martina, if you would take that back, and I'll be in follow-up with your colleagues for the 4 different societies, and then get everybody else like Jeff and Juliet and others involved in that. Thank you all very much. Jeff, thank you, my brother.
Thank
all right,
you.
y'all, take care.
Thank you.
Thank you. And now it's my pleasure to bring into the conversation our friends from the American Indian community. And I'm really pleased that Mary Owen, president of the Association of American Indian Physicians and director of the Center of American Indian and Minority Health at the University of Minnesota Medical School, is here. I'm really pleased that Dr. Aaron Payman is here, chairperson of the Sault Ste. Marie tribe of Chippewa Indians, and my friend Mary Catherine McNatt, who we've done these shows together before, is the chair and associate professor of the Department of Public Health at A.T. Still University and a tribal member of the Tigwa Nation out of El Paso. And let me begin, Mary, you know the drill, and the question I'm going to ask you, in your community, what is it that makes you anxious? What are you worried about, and where are your successes?
Hi, thanks for letting me be here today. It's great to be back with you. Our successes are, we've had quite a lot of vaccinations. We've been very successful in the vaccinations despite the high COVID rates. The things that makes us anxious are that despite a lot of the new funding coming out is very much with research, a lot of research offerings with funding base. In the Native American community, there is some historical use of data improperly without proper use of informed consent and proper gathering of informed consent. Again, it was mentioned in the previous panel. There's a lot of distrust of government due to research and improper use of data among the tribal units, as well as how we've been treated in the past. So also some of the reasons that we have been so successful with vaccines is the very inequities we have. We only have one health center there in the tribal nation. So it was not a question of where do we go to get a COVID vaccine. There's only one place. Culturally, we take care of our elders. So when our tribal members lead by example, for whether it's the medicine men, the tribal captain, or the chief, and they go and they say, hey, it's time to get a COVID vaccine. We don't have someone saying, no, it's my right not to wear a mask. It's my right to endanger individuals. They say, okay, we'll go get it. We want to take care of our elders. And so everybody complies, everybody goes, despite the fears, they go and they do it to care for the elders. So with so much funding relying on research coming up, that is something that we're questioning there, especially since a lot of it is going to pretty much anyone that applies for it. So we're kind of wondering who's going to come in and want to do more research on our tribe.
Thank you so much. Dr. Mary Owen, from the perspective of the Association of American Indian Physicians, what are you all seeing that gives you reason for concern and for optimism?
I also work in a clinic for the Fond du Lac Nation, and what I'm seeing here in Minnesota primarily, and I've heard from some of my colleagues as well, is that we're known across the nation for having good uptake of the vaccine in places like Alaska and Navajo country and other areas as well. But now we seem to be, at least where I'm at, seeing a little bit of a slowdown, a little bit more mistrust by our community. I just did a talk today, and there were a lot of questions, particularly by the people in the 30-ish range, 30 to 40 range, about why should I get this vaccine when I could just get the illness and ride that through, right? So a little bit of that, some mistrust around those issues, a lot of suspicion. People are really wondering I got questions about what's in the vaccine specifically, and I find that when you answer with the truth, people receive that really well. But the key is getting people, the audience is there, as we heard from the other panelists. There's so much mistrust in our community. It was interesting to hear about the different accountings we've had, uninformed or non-consented sterilizations of Native women as well. So we've lots of different reasons for Native people to have mistrust. I think what's important to know is that to get to our community, you have to go not just to our clinics, because our clinics are clinics. They still somewhat represent, even with people like myself and other Native doctors, they still represent some of those government systems. So we have to really use those trusted partners and go out into the community and find out where our Native folks are going. I think it's also really important that people realize that most of us now live in urban centers, and folks can be lost and not necessarily be going to our clinics as well. So we have to, again, find out where folks are. And then finally, the last piece I think is really important is that we've had people come to us and come to our clinics and expect to be able to do things through our clinics and not recognize the strain that's already there because we are so underfunded through the Indian Health Service. And that anytime that you ask our nurses or our providers to do something else, you need to think about compensating for that time, because it's time away from regular clinic duties that we just can't afford. I don't know how any clinic could afford it, but ours are even more stressed.
Dr. Owen, let me also ask you, in terms of the role of the physician as a trusted messenger in the community, is there is the physician role respected? Is it listened to, or are there others that are more important voices?
No. I think our physician roles are definitely respected and honored, but particularly, as a physician said earlier, when it's recognized that you are still part of your culture, it's even more powerful. When you're able to say words in your language, or say, what traditions are you following? Are you following traditions? Recognize the importance of our traditions in keeping us healthy. When you connect with when we are able to connect with our communities, that's when there's really buy-in.
Aaron, I saw you nodding. What are your thoughts, Aaron? Oh, we're losing your voice here.
You're muted.
Yeah, okay. Uh-oh. Let's see. Ellis, let me think here. What could be happening that he is? All right, we'll come back to you in a minute, Aaron. You might need to check your computer. You may be, honestly, it's not muted, so I'm not sure what. How about you do this? Log out and come back in, Aaron. Log out and come back in. While we do that, Mary, Catherine, you've been also at the School of Public Health at A.T. Still collecting data and information. What is your data and information, your research telling you?
We've looked at just various things, and really right now we're really looking at the importance of culture and how it actually helps with health. So for so long, the tribal nations have heard, if you're tribal, you're automatically going to get diabetes. If you're tribal, it's negative, you're going to face obesity and all these negative health issues. So one of the things we're really looking at is the importance of culture in a positive nation, in a positive light. I mean, so therefore, how the cultural connectedness can help improve your health, and you can do things together. How the importance of culture in combating stress, the importance of culture in working together to combat diabetes, and how being tribal can actually be a positive lead on your health, and how culture can work to improve your health. And so that's one of the things we're really trying to shift that mindset from tribal as a negative to tribal as a positive for health improvements.
Wow. And Dr. Owen, in that regard, how challenging is it to deal with the, I'll come back to you in a minute, Dr. Well, let me just finish you, Dr. Owen, and that is the notion of these pre-existing conditions. And were you all able to make a clear relationship? Did people understand the relationship between pre-existing conditions and the impact of this COVID pandemic on them?
I think people do. I think there's still a lot of question as to what is a pre-existing condition, which ones make you more at risk. I really appreciated Mary Catherine's remark, though, on the need. I find myself constantly needing to remind people that their health is not predetermined, that they are not necessarily going to get diabetes just because they're Native. They're not going to get COVID because they're Native, even though our rates are so high, that we can participate with the recommendations that the rest of the society is doing to protect ourselves.
Thank you for that. And Aaron, your thoughts, sir? Uh-oh, there we go again. Well, I'm so sorry, Aaron. You are, for those that do not know you, I think it is important that we recognize that we can probably go, and if you put in the chat how we can learn more about the Sault Ste. Marie tribe of Chippewa Indians and what you are doing. Because even though your voice is muted tonight, it is not muted in the society on a regular basis. And we're going to have you back, Aaron. You can believe it. So if you'll type into the chat, but let me say what Aaron is saying here is, let me begin by explaining that related data collection on the experience of the COVID-19 pandemic in Indian country is largely limited. Is largely limited to the Indian Health Service delivery system and limited service areas. He further says for his tribe, that is just 1/3 of his 43,000 tribal citizens. As data collection is left to states, in Michigan at the outset of the pandemic, American Indians were clustered and generalized under other. To his knowledge, tribal nation specific data is not being collected outside of the tribes. That is key. That is key. Finally, he will say, this is wonderful. I love it. Aaron, you are beautiful, man. Finally, Aaron says, I would like to say that with no specific funding coming from the federal government for the two-thirds of my people, much more resources are needed. American Indians prepaid for the promise of health, education, and social welfare with over 500 million acres of land ceded in treaties. We are uniquely a population with a federal right to health care. You have the worst of the worst outcomes, according to the 2018 U.S. Civil Rights Commission's Broken Promises Report. This makes those with the federal, let's see if the next part comes up. But anyway, I think of it just, that statement stands right there as, here we go. This makes those with the federal right the most vulnerable and the least funded. This is a major issue of inequity. Well, Aaron, your voice is, it would have sounded better coming from you, but I hope I read it halfway decently. The power of that, my friend, thank you very much. Thank all of you three. And I have to say that I think that we're continuing now to all learn that the same challenges that each of us are facing are shared. And I think a lot of us did not understand that. And so if we've done nothing tonight, we have again reinforced our common humanity, our common responsibility to each other. And I think we just have to start fighting these fights together as much as possible. And we're certainly going to try to do that more at the Black Coalition Against COVID. Thank you, Mary Catherine and Aaron. You are wonderful and we love you. And now it's my pleasure to bring on our last panel. And this panel is led by Dr. Leon McDougall, who is the president of the National Medical Association and one of my partners as a co-convener of our effort at the Black Coalition Against COVID. I'm also pleased that Ambrose Lane is with us, chair of the Health Alliance Network in Washington, D.C., and he serves on the Black Coalition Against COVID Steering Committee. And then there is our warrior, A. Tony Young, who has been a warrior for as long as I've known her, founder and executive director of the Community Education Group and co-founder of the Rural Health Service Providers Network. Dr. McDougall, you've heard all these other panels just talking, and isn't it interesting that the issues that we struggle with in the Black community are being echoed by every single other presentation? I don't know what that does for you, but what are your comments on that and where you see the challenges and the opportunities?
Well, thank you again, Dr. Tuckson. I was present in a opportunity to talk to Dr. Livingston yesterday and learned a new term, availability heuristics, is whereby the majority population doesn't necessarily see that Black, indigenous, and people of color are disadvantaged, and in fact, think that they're more in a disadvantaged position, and based on what they see on television and other media platforms and the mistruths in social media. So when we expand the coalition beyond that group, there may be some resistance in wanting to count who's receiving the vaccine, for example, to help to ensure that those communities that we know are being adversely affected by hospitalization rates and deaths are actually now receiving vaccines. Only CDC says only about 55% of people being vaccinated, we even know what their race and ethnicity is. So the Black Coalition Against COVID is outstanding. We also need partners and to help to mitigate COVID-19.
Thank you, Leon. That is terrific. Let me turn to Ambrose. And Ambrose, you are on the ground in one of the more socially disadvantaged communities in the District of Columbia. You're involved with the grassroots on a daily basis. What are the challenges you're up against, and do you see reasons for optimism, or are you just mainly concerned?
Well, there are many challenges, and those challenges certainly reared their head during COVID-19. I mean, you know, the Black community, particularly low-income Black communities in Washington, D.C., already had a dearth of services located within those communities. So when COVID hit, there wasn't really the infrastructure to be able to handle the pandemic. Now it seems, and these are positive things, the Department of Health has partnered with the Black Coalition Against COVID, but also community-based organizations, faith-based organizations, as well as, of course, the FQHCs and pharmacies. And we just had a meeting on Friday, and there were 75 entities represented meeting with the Department of Health to talk about the next phase in terms of the vaccine output. And this is very promising because if the Department of Health takes a page out of what is developing in these relationships, then it can develop this infrastructure in a stronger way in the future. And that's one of the things that's concerning. So right now, what we're really concerned about is the age group between 20 and 35. 75% of seniors have already been fully vaccinated. In terms of the city, only 33% of the city has been vaccinated, which is under the national rate. And part of that is driven by the 20 to 35 age group, which are still very hesitant in terms of getting the vaccines. And so we are redoubling our efforts by standing up more community-based vaccination sites in places like Ward 7, places like Ward 8. I know I live in Ward 7. And we think that this, especially targeting young people with messaging and targeting young people in terms of coming into the community, being more nimble, being more mobile, we think that we can address the issue, but it is tough.
Ambrose, would you just say one more word about the messengers? I know that that physicians are certainly a source of good messaging, but what are you hearing on the ground about the notion of who are the intermediaries that can carry the word?
So this is a real interesting question because we've done some focus groups and some interviews with particular age groups. And so what we find is that the older age group, those that are really over 40, 45 years old, they do look towards the physician as the trusted messenger. But when you come to the younger age group, the physician is not necessarily the most trusted messenger. And by the way, neither are celebrities. So in that age group, the more trusted messengers are peers, as well as community leaders that they are aware of, that they know of, that have done work and have worked with young people in their communities. And so when you look at the messengers, it's not a one size fits all type of thing. And so to the extent that we can engage more young people to be good messengers or ambassadors, as Reverend Curry says, and engage more community leaders, then we will begin to get at the root of the mistrust among the age group 20 to 35. And so we think that that can happen, but it is tough. It's an uphill battle.
So Tony Young, how does that sound to your ears?
Well, it sounds amazing to my ears because that man just said he was over in Ward 7 where I'm born and raised. So, there we go. We got a good warrior out there east of the river and we're proud. So thank you very much, sir. I think that one of the things that when I listened to all the panelists this evening that I really took away from it is that we need to be thinking not just about the impacts of COVID, but we have to start thinking about how these strategies will be applied down the road. COVID is here and now, and yes, we need to get people vaccinated here and now. But one of the things many of the panelists spoke about is our need to deconstruct silos. So whether that's the HIV silo that many of us have worked in, substance use disorder, people talked about diabetes, or even race and ethnicity. We need to really start thinking about how it is that we build infrastructures in our communities that are most in need. As you know, I work in rural communities in West Virginia and across the United States. And one of the things that I've talked about a lot with our team is certainly the issue of deconstructing the silo, but the mobility and portability of services. We're now hitting that band of individual that didn't run to the vaccine when we clicked the light on and said, we've got vaccine. We just didn't do it. And some of those folks are going to need us to be able to bring vaccine to them. Every time I come on here, I talk about my Dollar General idea. Looks like Yale has picked that up also. They've got some data for that.
Hold on, Tony, wait a minute. A lot of people don't know your Dollar General thing. So slow that one down and tell us what you mean.
So here's what I think. I think if we take a store or a business like Dollar General, many people don't know that Dollar General has the largest retail footprint in the United States of America with over 16,000 stores. And what Yale has now figured out, because I thought it was just kind of a wacky idea, but what Yale has also figured out is that those stores, given their parking lots, could really increase vaccination amongst African Americans in urban environments and also white folk and poor and rural folk by 34% if we were to do kind of a merger of services. So if we put a 10 up there, either with FEMA or retired healthcare workers or others, but what we could also do is not just do COVID vaccination or COVID screening there. We could do HIV testing. We could do blood pressure measurement. Here's some, we could do Hep C screening. And the other thing that we could really do is, I think, really address the concern I think some people might have with Dollar General. Did they create the food desert or are they responding to food deserts? The other thing that we can do is, particularly with Black farmers and other farmers, is get them to have, a little farmers market there once a week or once a month, whatever Dollar General would allow us to do. But what it would do is also give us, again, portability and mobility of vaccination. People, given the data that we know about Dollar General, are coming to Dollar Generals 2 and sometimes 3 times a week. By the time they pass that thing the third time, what we can begin to have conversation with them about is maybe not about vaccination, but about the importance of getting their families protected. Because that's the issue that is really going to resonate with many of the people in rural and red states is, look, you don't want mama to get COVID. So you get vaccinated, so you impact the household. And those
I like that. I like that. I love the Dollar General. I presented the ice cream truck scenario. In other words, we have ice cream trucks that roll in the summer all the time. They go into all the little nooks and crannies in our communities. We can take a refrigerated truck to refrigerate the vaccine, take some students and young people, canvass the community the day before, or the day, 2 days before, and say, we're going to be here on Saturday between 1 and 3 with the vaccine. Get the J&J vaccine, which is a one and done vaccine, go into communities and make it available to communities. So the Dollar General idea and the ice cream truck idea,
well,
I think
before you go too far though, Dr. McDougall wants you to say also that there's a place called the Minority Physician's Office. And Dr. McDougall, can you be as good as the Dollar General or the ice cream truck?
Yes, and usual sources of care where people are already seeking their care for primary services, such as preventive vaccinations. So, especially now that the age group for availability for the vaccine is decreasing to 12 years of age and will continue to descend, those pediatric offices, those family practice offices in the Black community, the Black physicians, the Black pharmacists, the Black nurses. We're there, we're in those communities, and the strategies that you're mentioning complement that. So that's innovation. That's necessity is the mother of invention. So I'm very pleased with what I'm hearing.
And I just want to add one more piece, because I think Mr. Lane, Mr. Ambrose has a great idea around the ice cream trucks, because we have actually just proposed to CDC that we would do this in rural communities, but we would just get Sprinter vans and we would do it, and we would create hubs within the state of West Virginia where we would have refrigeration points so they could address multiple counties. But where they would go is to residential treatment facilities, any sort of kind of insulate facility where individuals are going to be housed for at least 7 to 10 days, if not longer. So you could now that we have the J&J vaccine back on market, we can do one and done. But these trucks would be able to go there, do the vaccination for people who may not have access to vaccine. We've got vaccine available in this country. We've got a dose available for everyone, but not everyone has access. And
are you going to need? So is the funding there to advance these kinds of innovative ideas? Are people listening to you?
I hope they're listening to me, and I hope my check is in the mail. I want one of those big Ed McMahon checks when I get my check. I'm going to be all over the place and say, if it wasn't for Dr. Tuckson, I wouldn't have this check.
Well, I'm going to see what we can do to help you out. Well, listen, guys, thank you all, Leon, Ambrose, and Tony. I really appreciate your, this has been a great panel, and I appreciate it. And there is going to be follow-up, so we'll talk about that in a couple minutes as we end up. I'm going to bring back Dr. Georges Benjamin and my very good friend and other co-founder of our National Health Black Coalition group, Martha Dawson, president of the National Black Nurses Association. And what I'd like you to do, and I know you've been listening carefully, both of you, Martha Dawson and Georges Benjamin, I know that both of you have been taking notes and thinking about what you have heard. Let me just be very clear to our audience. We are going to take this conversation and the things that have been made and bring them to the powers that be. The powers that be were here. We also have access to the powers that be across the government. And we're going to take what we've learned here and bring that forward so that they might be able to better implement the programs that they're designing and that they're working on. And so with that, Georges, let me start with Martha first and then go to Georges and sort of see, Martha, what did you hear that is going to stay with you?
Wow, so much. I tell you, this was another great event. But I learned things such as, we are making progress, but there's still work to do. And we have to do this work together. It was amazing to hear the similarity across the different races and ethnicity in terms of past experiences and also where we are today. So we have to partner to make sure that going forward, we don't just have a village, but we're going to need villages to get this accomplished. And I must say that I love Dr. Tony's suggestion about let's go into the Dollar General stores. If they have 16,000 stores, I'm looking even beyond COVID. That's where we need the minute clinics, okay? I love the ice cream truck, but let's do the food trucks as well. Let's do every 4th of July event. Because what we're hearing is that the progress we've made is that the deaths are down for our older adults by 2%, but we're seeing more hospitalization for our 59 years and younger. Our 35 to 25-year-old, our college students, they're about to come home. We need to get them vaccinated. We need to make sure that we have the right messengers out there. And that's what we have been doing. We heard about the data, that Ad Council have, and that information is going to be made available to us through blackdoctor.org and the Black Coalition Against COVID. However, we also heard about we still need better data. And we need to have our scientists and our medical providers, our health professionals. We have to continue to demand that we have accurate data. We heard about the inequities in distribution. And yes, we're going to continue to address that. Having 2 million people that have been vaccinated, we still have so many more millions to go. 30% have gotten the first dose, 29% both, but that is not going to help us to control this virus. And we need to be very deliberate about educating our population that this is a public health crisis, okay? So that the only thing we can do is get the vaccination and continue to practice all of those things we've been practicing. Let's not get out and party too soon, okay? Because it's not time yet, but the time is coming closer that we will be able to do that. And so as I sit here and think about, so what next? What should we be doing next? I heard we need to look at the funding. Where are we sending all of the dollars? They need to be coming to our communities. We heard about the research dollars are increasing. Dr. Reed, I need you and our other colleagues that look like you, whether they be pharmacists, physicians, scientists, you all need to be leading some of this research. We need for the dollars to come in. And the Black nurses are ready to partner with you to make sure that you have your support and that happens. We're coming up on Nurses Week. So I want to say happy Nurses Week to all of those nurses that are out there, been on the front line. I mean, I've had some of my chapters and I get an email saying, we vaccinated 1,000 people this week. We just need more vaccine. We have to continue to partner with our faith-based organization, our civic groups. The Urban League is a part of this group, but we have to reach out to the NAACP. We have to go to the Boys and Girls Club. We have to go to all of these sport events. When it's time for our high school and our colleges to start putting their basketball and football players and baseball players back out there practicing, we need to make sure that our children are vaccinated.
Thank you.
We can't forget about the homeless. We have to step into that population. We have to be into where the prison population is at this time. So all of these things that we're doing, and I was so proud to see that we had so many of our Native Americans and Hispanics, Filipinos, and others on this call tonight, because we are in this together and we can only get out of it together. So that's important to me. I love the innovation. Let's innovate. Let's think outside of the box, and let's never give up. I know the work it's been hard. I mean, I had to take a nap before this meeting tonight, but it was so important for me to listen and to continue to learn and to let people know that we, the Black Nurses Association, we support every effort that is going on. We're here to work. We're rolling up our sleeves. We will educate. We will vaccinate. And we will not quit until we have achieved the outcome that we want. And we're headed in the right direction. But we're going to work with our young people.
I'm going to pass the plate to you. That was beautiful. Thank you, Martha, as always. And Georges, the last words from you, and how did you, what stayed with you?
Yeah, there was so many amazing things. And Dr. Dawson, thank you very much for laying those out. Let me just say three things. Number one, Allender brothers and sisters, and we need to pay attention to that. I didn't want that to get missed. Number two, people who are not getting their second shot. I heard that they're getting infected, and I heard that as a real concern from our Hispanic brothers and sisters. And third, at the end of the day, we're almost at the end of the road on this. And that means we're going to have to roll up our sleeves, redouble our commitment, and get this job done. And I hope that people will listen to everything that they heard tonight and just take those measures and run with it.
All right. Thank you, Georges. Well, as we wrap up this evening, let me say these words in closing. First of all, thank you to the White House COVID response team, the White House Community Corps, We Can Do This campaign, the CDC Foundation, our 4 minority medical societies, the National Black Nurses Association. Special thanks to APHA's Alliance for Disease Prevention and Response, and again, the wonderful, outstanding Susan Poland. Thanks for Salud America, Health Alliance Network, Asian and Pacific Islander American Health Forum, Rural Health Service Provider Network, A.T. Steele University, the Sault Ste. Marie Tribe of the Chippewa Indians, Mixteco Indigenous Community Organizing Project, Urban League, Ad Council, and the blackdoctors.org. Georges, we are going to work our tails off to bring all the points that were made to the people in positions of authority that can deal with all of these recommendations. And so we will do that. As for, this show will be re-aired in about 5 to 7 days. We will let every one of the constituencies that were participating in this know when the re-airing will be on blackdoctor.org. And so you will have a chance to have it, and it'll be archived as well on the Black Coalition Against COVID site for those who want to come back and refer to it. So we will follow up in a very serious way. This is not the kind of conversation that can just be had and then walk away and go take up something else. This requires attention. And the last word from me as the moderator, I will say, is that I think my soul has been touched tonight by the testimonies of all of our colleagues. So often we, as people of color, are only seeing the reality and the painful reality of the world through our own silo. But now that we see that the same issues that we have about being invisible, as Juliet Choi said, or whether we are being people who are being abused and our women who have been inappropriately treated through the healthcare, is not just an African American issue. It is an issue that came up for every one of our other communities. We're all sharing the same sadness, and I think we would be remiss if we didn't have a special shout out to our Asian brothers and sisters who are being accosted on city streets by other people. We've just got to come together and respect each other and hold each other's hands together and remember that the value of human life. So thank you all for joining us. We've appreciated this. We will be following up. Take care. See you next time for the next town hall. Bye-bye.
I'm Henry Louis Gates Jr. We are a people of resilience. Never giving up, always giving back. No matter what happens, we fight through the pain. We protect our traditions. We uphold our excellence. So let's protect our lives with vaccines we can trust, so we can embrace what matters most.